And when I'm talking about torsion of pelvic organs, we most commonly talk about ovarian torsion or adnexal torsion. But it is not only adnexal and ovarian torsion, although most of our lecture will be dealing with that because that's the most common type of torsion we see. But also, I'll also be discussing the rarer types of torsions. Now, the references for this, I always tell you my references in case you want to go back and read. So it's very varied. As I said, no one book is giving this properly. Even the standard book, that is T-Lind's, which is our standard book for operative gynae surgery, also just mentions a paragraph. Novak's, Jeffcoat, and other standard books, just a few paragraphs again. So a lot of my information is from researching online. UpToDate is a very good source which I have used, and also ACOG guidelines are there for adolescent or pediatric age group torsions. There's some nice guidelines and BMJ guidelines also, but nowhere is it given comprehensively in one place. So I've put a lot of effort into making this a very comprehensive lecture, which should be enough for both your exams and for clinical practice. And I've put in a lot of my own input from here, from what I have seen in practice. And I've put two videos also in the end from my own practice where you will understand better. Now, when I say pelvic organ torsion, what are the organs that can undergo torsion? So we can have torsion of normal organs, okay? And in torsion of normal organs, we can have, just a second, yeah. We can have, as I said, the references for this are varied, okay? And there's no proper place where this is given. So I've compiled everything from different sources and tried to help you out. So what we do now is when we discuss about torsion of pelvic organs, what are the pelvic organs? We have the uterus, we have the fallopian tube, and we have the ovary, right? And so a normal organ can also undergo torsion. It doesn't have to have a pathology, like we say ovarian cyst torsion or dermoid torsion. It is not necessary to have a pathology. Even a normal looking ovary can undergo torsion. Even a normal looking fallopian tube can undergo torsion. Even the uterus can undergo torsion. So when we talk about torsion of normal uterus, to some extent, a pregnant uterus is already torted slightly towards the right, what we call as dextroversion. You must have, whenever we examine a pregnant uterus, we always have to correct the dextro rotation. That dextro rotation is a type of physiological torsion. It is called pathological when the uterus has rotated by more than 45 degrees. Now, this is very rare. Okay, you hardly ever see it, but it's usually associated with a Müllerian anomaly. Okay, because otherwise the uterus is a very fixed structure. It is very unlikely to undergo torsion, but rarely it does. Okay, and this can present as an acute abdomen in pregnancy. Okay, I have seen one case of uterine torsion which presented as a 34-weeker patient who had come not with pain, surprisingly. She had come with severe fetal growth restriction. There was a reversal of diastolic flow. This was when I was doing my residency. And she was planned for an emergency. She was referred from somewhere with reversal. She was planned for an emergency cesarean section because of severe fetal growth restriction. So what we did was my senior faculty, we took her up for cesarean, and he gave the incision on the lower, on what he thought was the lower uterine segment. But what that was actually the posterior part of the uterus, and what we thought was the UV fold was actually the rectum. So the baby it had undergone a 180-degree torsion, the uterus, okay, and torsions have been described of a pregnant uterus from 70 degrees to 270 degrees. That much torsion has been also described. This was a 180-degree torsion where the baby was delivered posteriorly. And then we realized that something's wrong. Something looks very grossly wrong. So then we realized that this is what has happened. The baby was delivered, the torsion was corrected, and then the rectum was repaired. So this is a rare scenario, but you should remember dextroversion or dextrotation is something which happens normally, physiologically. There will be some extent of dextrorotation, and this should be corrected both at the time of cesarean section. So one way to, although it's a very rare scenario, when you're doing a cesarean section, always try to identify the round ligaments. If you're able to see the round ligaments, you know that the anatomy is correct. If you're not, that means something is wrong. So always keep in your mind, cesarean ke time, always look at the round ligaments. The second thing you should remember is that usually torsion the uterus can present, the definition if of proper torsion of the uterus in pregnancy is if it's more than 45 degree, but it can present usually as abdominal pain, usually in early pregnancies, usually in a Müllerian anomaly, but rarely it can present, as I told you, as something like fetal growth restriction because the uterine arteries were stretched, there was very less blood supply going to the uterus. Also, the normal tube and the normal ovary can also undergo torsion. Okay, and this is very common. I mean, I won't say very common, it's actually a rare situation, but in the rare situations, it is more common in girls. That means girls who are in the adolescence or even childhood. Okay, so a normal ovary can undergo torsion. So the young girls, adolescents, the ovary is bulkier, okay, especially the pubertal age group, and there is more hypermotility of the supports of the ovary, that is the ovarian ligament and the infundibulopelvic ligament. So in fact, you see torsion common in the young girls. Most of the torsions I have operated have been in young girls or in pregnant women. In both, the anatomy is such that the ovaries become bulky and they are prone to undergo torsion. Even young girls with polycystic ovaries, because the ovarian bulk is more, they undergo torsion more commonly. So a normal ovary, a normal tube can also undergo torsion. Now, when we talk about abnormal organs, so a asymmetrically enlarged uterus is more common to undergo torsion. As I said, a Müllerian anomaly or something stuck to the uterus is more common to undergo torsion. Although, as I said again repeatedly, uterine torsion is something you will almost never see in your career. I have seen in the last 20 years, I've seen only one case. Another commoner one is if it's a pedunculated fibroid. I'm sure many of you have heard of this torsion of a pedunculated fibroid. That is a subserous fibroid because it is with a pedicle, so it tends to undergo torsion. Also, an abnormal fallopian tube, especially if there's a hydrosalpinx. Now, very big hydrosalpinx may not undergo torsion, but smaller amounts of hydrosalpinx can undergo torsion. And when you do a laparoscopy, when you do an operative procedure, the fallopian tube you may think is swollen because it's undergone torsion. Remember, torted organs will become edematous, but they may actually be a hydrosalpinx, and that has led to torsion. Also, parafimbrial cysts, para-ovarian cysts, these undergo torsion also quite commonly. So, an abnormal pathology in the fallopian tube. And of course, what we're going to discuss mainly is ovarian lesion or an enlarged ovary is what we commonly encounter that has undergone torsion, like ovarian cyst, like a dermoid. These are very prone to undergo torsion, especially if they're large in size.